और जमीन में है, सब इस तस्वीर करती हैं और वो गालिब हिकमत वाला है।
Jazakallah, Dr. Umar. I would now like to request Dr. Daud to formally begin the academic session of Pakistan Society of Pathology Congress. Dr. Daud.
In the name of Allah, the most beneficent and merciful. I am Dr. Daud Ghilzai, consultant gastroenterologist and hepatologist at Bolan University of Medical and Health Sciences, Quetta. I welcome you all in 21st Annual Congress of Pakistan Society of Hepatology in this beautiful city of Zinda Dilane Lahore. I feel honored to moderate this particular session, which is non-alcoholic fatty liver disease. The aim to present you with an update on the epidemiology and public health relevance of this condition. Together at this Congress, we will address key challenges in the clinical practice and drug development in 2021. I'm glad to see you all sitting in front of me after long held restrictions of this lethal pandemic. Today, we have a panel of world-renowned experts who will share their views on this burning issue. It is my sincere pleasure to introduce you with our chairpersons of this session. My first chair is Professor Arif Siddiqui. He is Professor of Medicine and Head of Department of Pakistan Kidney and Liver Institute, Lahore. Unluckily, he is not here as he has got COVID positive. My next chair is Professor Mozamuddin. He is former president of Pakistan Society of Hepatology and consultant gastroenterologist at Quetta. Professor Mozamuddin. Our third chair is Professor Khalid Shah. He is working as Professor, Dean and Chairman of Medicine and Allied Sciences at Bolan University of Medical and Health Sciences, Quetta. He is Head of Department of Medical Unit 4, Dr. Khalid Shah. Our next chair is Dr. Mughis Atar. He is Professor of Gastroenterology at PMC Allied Hospital, Faisalabad. Dr. Mughis Atar. My first speaker for today's session is Dr. Lubna Kamani. She is an Associate Professor of Gastroenterology and Hepatology and Director GI Residency Program at Liaquat National Hospital, Karachi. She is the recipient of Outstanding Graduate Award at Bakai Medical College, Karachi, and in 2006, and have a particular interest in management of hepatitis B. Dr. Lubna Kamani.
How can you get that talk on Zoom? आपके पास उनकी इनपुट है
So that's why I'm recording my lecture virtually. So the topic given to me is very important for NAFLD and emerging epidemic. So what's the definition of NAFLD, which is non-alcoholic fatty liver disease? There is evidence of hepatic steatosis either by imaging or by histology, and there are no causes for secondary hepatic fat deposition or accumulation, such as significant alcohol consumption use of teratogenic medication or hereditary disorders. And it is further categorized into two diseases entities, which is non-alcoholic fatty liver and non-alcoholic steatohepatitis, which is NASH, and which leads to fibrosis and cirrhosis. So what is the WHO definition of overweight and obesity? WHO classifies overweight as BMI between 22 to 25 kilograms per meter square, or obesity as BMI greater than 25 for Asian populations. Different for Asian, different for Caucasian. And there is an Asian Pacific Working Party for NAFLD, which has also included the waist-hip ratio in the regional criteria, emphasizing the visceral part and the central obesity as key, and the waist-hip ratio of more than 0.9 centimeter men and 0.85 centimeter in women of the body. So NAFLD burden worldwide, if you see that 50 to 60% of the population of NAFLD is in developed countries, USA and in European countries. And if you talk about Southeast Asia, there is ample data from nearby country, India, and almost 1/3 of the population have NAFLD. And the lowest prevalence of NAFLD is seen in African countries, the least developed. So what's the cause? The basic cause is the environmental factors. We eat a lot of these days junk food, the fried items, the fast food, and as we've been going on into the pandemic, we had lockdown of various intensity across the world, and which further limited our physical activity. The gyms were closed, the schools were closed, and we had the major activity in the house was the screen time or the TV or the mobile or the Facebook. So these were the major, and these all come into sedentary, lifestyle that the entire day we used to eat, especially the children, because there was no outdoor activities, there was no schooling, so they used to sit the entire day in front of their screen and intermittently take junk. This is the major environmental factor, and this is a concern because during a pandemic, there's rising increase in childhood obesity seen, and WHO actually has sent a warning, has given a warning basically that in the next few years this will be a major problem to tackle. So are we dealing a pandemic within a pandemic? So what are the key facts? Worldwide obesity has nearly tripled since 1975, and it comes with no surprise. In 2016, more than 1.9 billion adults 18 years and older were overweight, of these 15 million were obese. Approximately 40% of adults aged 18 and over were overweight in 2016, and 13% were obese. Most of the world's population live in countries where overweight and obesity kills more people than underweight. 39 million children under the age of 5 were overweight or obese, and over 340 million children over the age of 5 years were overweight and obese. And the good thing is that obesity is preventable. So we need to work on it. It is preventable, it is reversible to certain extent. So this is the cartoon which represents that how fatty liver develops. So the first stage is the insulin resistance among the adipose tissue, which increases the free fatty acids, and together with the excessive caloric intake, there is increased insulin production, there is increased glucose, and there is decreased adiponectin. Second stage is compensated steatosis, which causes increased insulin resistance, there is increased lipogenesis with increased TGs, increased VLDL, which gives rise to oxidative stress or the beta oxidation, which is leads to steatohepatitis and causes increased plasma glucose concentration, which further gives rise to type 2 diabetes mellitus. And the fourth stage is fibrosis, where there is macrophage activation, which causes liver fibrosis. There's increase in TGF, beta, and other factors, increased HSC activation, and decreased. This is a cartonic diagram that how the fatty liver fat deposition works. It enters the hepatocyte and what it causes, and then ultimately causes liver fibrosis. There are various Nash scoring systems in morbid obesity patients, and there are 5 factors actually, 6 factors: hypertension, type 2 diabetes, ACA, dyslipidemia, and the epidemic. And the risk of Nash depends upon these factors. If there is a scoring point, if the score is less than 2, the risk of Nash is low. And if the score is more than 6 or it's between 6 or 7, the risk of Nash is very high. So these are the various steps or stages of fatty liver. It starts with steatosis, there is Nash, there is fibrosis, decompensation, and death ultimately. There is global prevalence of NAFLD is approximately a quarter of the world population. It's suffering from fatty liver, so you can imagine the gravity of the situation. So, and it takes approximately 7 to 8 years from Nash to cirrhosis and next decade from cirrhosis to decompensation. The patient also has ample time to correct this, and to some extent in initial stages, this condition is reversible. The major cause of death in these patients is of course cardiovascular, followed by malignancy, liver-related, and there is a chance of ACC progression, which is 1% per year. So the liver mortality is independent. Fibrosis stage is independent factor for liver mortality. The higher the fibrosis stage, less will be the survival. So we need to prevent liver from getting into the final stages of cirrhosis. So what is the management? And one management is important. So our therapeutic rationale for therapy, for any therapy, is insulin resistance and diminishing the oxidative stress, because we know these are the 2 key players. So the goal of treatment is to reduce the histological features and improve insulin resistance, which ultimately will improve the liver enzyme level. So the NAFLD treatment as per stages, if we have early stage NAFLD or intermediate or late stage, so if there is steatosis alone or Nash with cirrhosis, the one important thing is lifestyle intervention such as diet and exercise. If with lifestyle intervention we are unable to reduce the weight of the patient, or if there is no significant improvement, then there is some data, upcoming data, that bypass surgery or sleep gastrectomy can play a role in reducing NAFLD by reducing the weight of the patient. Then there are certain pharmacological therapy. Currently, there is no FDA-approved treatment for NAFLD, but there are various ongoing trials in phase 2 and phase 3 studies. So we are hoping that in the near future we might get some treatment. So we have vitamin E, intoxified, there are some insulin sensitizers which might work, and there are some therapies in development which is obesogolic acid and PFP5. Once cirrhosis development, we have to screen this patient for ACC, and we have to screen this patient for esophageal varices. So first thing comes first, the lifestyle intervention. Weight loss generally reduces hepatic steatosis achieved either by hypocaloric diet alone or in conjunction with increased physical activity. And at least 3 to 5% of body weight appears necessary to improve steatosis. But if we need to improve necroinflammation, we need to have weight loss of at least 10%. Exercise alone in adults with NAFLD may reduce hepatic steatosis, but its ability to improve other aspects of their liver histology remains unknown. So there are 3 main components in lifestyle intervention. First is general, diet, and exercise. So in general, the weight loss should be more than approximately 5 to 10%, or ideally more than 10%. We need to take care of psychological barriers in these patients, because this is not easy. Sometimes patients have psychological problems which compel them to eat more. So a psychologist on board will be very handy in these patients and will take care of the psychological aspect. Then we need to identify physical barriers to lifestyle change. If they are unable to go to gym, or if they are unable to go out of the house, or if there is any access to park, If there are any problems like knee problems or back problems, sufficient sleep is linked to healthy weight basically. Sufficient sleep is important and maintain weight loss, which is also very important. So, zero calorie beverage in place of sugary beverage, more active lifestyle, portion control is important. This is also a part of religion that we need to keep one part of the stomach empty. So don't, fill up the stomach 100%, limit alcohol or no alcohol in our religion. Coffee, black coffee has shown some improvement in effort. Use stairs when possible where we don't need them. Avoid late night eating and avoid sugary beverages. The last meal and before you go to bed, the last meal should be 2.5 to 3 hours before you go to bed. So the diet restriction is important. 500 to 1,000 calorie diet restriction. You need to decrease the low carbohydrate. Carbohydrate should be less than 40%. Increase your vegetable and fruit serving. Replace calories with polyunsaturated fatty acids or monounsaturated fatty acids. Use extra virgin olive oil, nuts, olive, and use oily fish. Avoid herbal supplementation or non-prescribed treatment. Avoid trans fat, limit saturated fatty acids. Avoid, and they had little or no knowledge about their disease, despite being diagnosed genetically. Further, general population is willing to accept being overweight or unhealthy eating habits, but their willingness in initiating real-life practical steps to manage NAFLD is lacking. Many patients, and I see in my clinic also, they are obese, the BMI is 28, 30. When I ask them that whether you do any regular exercise, they say no, we don't. We know that we are overweight, but we are not into any exercise program or we don't do any exercise on daily basis. So in summary, the standard of care for all exercise is a must. If you're overweight, then you have to weight reduction. But if you are not overweight, then at least you need to exercise to make yourself fit for your own health, for your muscle health. Control of diabetes, hypertension, and dyslipidemia is the key. Vitamin E and pioglitazone for biopsy-proven Nash. There's pioglitazone in India. It's still not FDA approved. And then you have to screen these patients if they're cirrhotic or regularly with HSC and with for esophageal varices. And you have to take care of other systems like cardiovascular systems. And as these patients are obese, they have higher chance of malignancy as well. Future medical treatment, we were anxiously waiting for allopurinol, but then it's a failure. There are ongoing multiple trials which I talk about. And let's hope and pray that we get some medication. There's success interim analysis of obetofolic acid, and I hope it might hit on the roads of the fatty liver treatment. So till then, lifestyle modification and maintaining healthy diet is the key. Thank you for your attention and thank you, the organizer, for giving me this opportunity.
Any person from the hall who has vehicle number BND 160, kindly park the vehicle in the parking area. Our next speaker for today's session is Dr. Shahid Habib. He will join us live. He is a consultant gastroenterologist and hepatologist at Southern Arizona Veterans Affairs Healthcare System, Tucson in Arizona, USA. He has particular interest and numerous publications on management of chronic liver disease, liver transplantation, drug-induced liver failure, HCC, and its surveillance, and NAFLD. He has been awarded with Certificate of Excellence by University of Colorado, Pakistan Society of Gastroenterology, and Certificate of Merit by American College of Physicians. Dr. Shahid Habib will talk on tracking NAFLD, what we know about the pathophysiology in 2021. Dr. Shahid Abid.
Hey, good morning. Assalamu alaikum. Thank you very much. I need a authority to share my screen.
लैपटॉप तो ये वाला क्यों?
आपने तो कनेक्ट करी यहाँ पे आवाज नहीं आती। इसका साउंड बंद होना है क्योंकि इसके एक्सटर्नल आउटपुट है। यहाँ पे कुछ स्पीकर लगा है? नहीं उनका माइक भी नहीं हो रहा।
ऑडियो यहाँ से तो ओपन।
नहीं हमारी ओपन
Hello.
Can you check your audio input, please?
Yes, I'm checking that, but I need a authority to share the screen.
Yes, please. I'm giving it to you right now.
Okay.
Okay, you're done. आपको मैंने अभी कोर्स किया तो उसको मैंने कोर्स कर दिया। हमने तो उसको आउटपुट लेनी है। हमारा प्रॉब्लम नहीं है। उसका माइक बिल्कुल ले रहा है, साउंड नहीं कर रहा। वन टू कह दो कि हम तो प्ले कर रहे हैं।
More. I don't.
So they have to give you authority to present.
Yeah.
So it's
No,
called
no,
like
no,
share
no,
screen
no,
or
no.
presentation.
I'm not getting this. Do you hear me now? Yasir, do you hear me? Organizers, do you hear me?
इसके साथ नहीं चलेगा,
चलना चाहिए ना।
नहीं चलेगा।
इसको चेंज करना है। इनका माइक ग्रीन होगा। That is not green. हमारे यहाँ पे रेडी है।
We request from all of the participants in the hall, please keep wearing your mask. If anybody who has not have any mask, the masks are outside the hall, and also hand sanitizer is also present. Please keep wearing the mask.
What's your sound? Yes. All right.
नहीं आई।
And no, there is some problem. यहाँ नहीं लगानी। Allow. Can we play your presentation?
सर की presentation से तो play करूँगी ना मैं ठीक है। अरवा तुम कर।
सर की पहले आई हुई है।
हाँ वो यही कहते हैं।
तो फिर उसमें पड़ी होगी ना हमारे।
हाँ तो आप चला दो।
It's not on our server at the moment.
For inviting me to this prestigious conference, Pakistan Society of Pathology 2021. And today, the topic of discussion is managing a patient with non-alcoholic fatty liver disease. Hepatologist alone, doing it alone, or multidisciplinary team-based approach. So answer is, might take multidisciplinary team approach is the best approach. My slogan is, it takes a team to see the liver. What we need to treat NAFLD. What are the resources needed to accomplish?
नहीं हमारे इनका मसला भी नहीं है
हमारे इनसे क्लियर है कोई कंफर्म करा था
नहीं वो सब चेक कर लिया
Assalamu alaikum. Thank you very much for inviting me for this prestigious conference of Pakistan Society of Hepatology 2021. And today I've been assigned to talk about discussing the pathophysiology of non-alcoholic fatty liver disease, what we know as of 2021. During this talk, I'm going to talk today what is the key pathophysiological concept and etiology of non-alcoholic steatohepatitis. What are the steps of development of Nash, leading to the steatosis being the first step, inflammation and fibrosis. What is the speed of progression from NAFLD to Nash to cirrhosis and decompensation? What are the factors associated with progression of the disease? And what are the key foci based upon the pathophysiology to treat non-alcoholic steatohepatitis? The pathophysiology of the concept of pathophysiology of non-alcoholic fatty liver disease has evolved in the past few decades. In the later part of the previous century, our understanding was like two-hit pathogenesis. It means that the insulin resistance leads to triglyceride deposition in the liver, thus steatosis, rendering it more susceptible to the action of second hits such as oxidative stress, ATP depletion, and endotoxins. Finally, leading to inflammation, fibrosis, and cancer. This theory has been replaced by the multiple hit pathogenesis. This states that multiple etiopathogenic factors act in a parallel or sequential and somehow synergic way on a genetically predisposed subject to cause non-alcoholic fatty liver disease and thus defining the spectrum of the disease phenotype. Particularly, some patients will develop non-alcoholic fatty liver disease and consequently Nash, but others will directly present inflammation and fibrosis, probably because of the influence of genetic and epigenetic factors. So we don't know how the disease starts and where it starts, but we know that there is a eating behavior plays a key role in lifestyle modification and lifestyle, the way we live our life plays a key role. So the nutrients, either the macronutrients of fat, carbohydrate, protein, or micronutrients, when they get into that, they lead them into the fatty liver and subsequently they turn into insulin resistance, lipotoxicity, lipotoxic stress, and cellular damage, inflammation, and pathogenesis. The altered new energy balance or impaired energy balance is the key concept that lead to the steatosis. And when we talk about the abnormal lifestyle, that means there are several factors come into play, which includes environment, personal choices, and psychosocial issues. And that lead to excess calorie consumption, unhealthy nutrition consumption, inactivity, and sleeplessness. And eventually it turned into impaired energy imbalance with a more calorie consumption and less calories used. What we know when we talk about the diet playing a big role here, so what evidence do we have that supports our concept? So there are a few things I'm going to tell that can aging independent of dietary calories and modulation lead to steatosis. So just calorie consumption access independent of the calorie consumption can aging. Yes, answer is yes, we have a strong evidence. What is the relationship between insulin resistance and steatosis? There's a bidirectional and synergistic relationship. What is the relationship between insulin resistance and hepatic fibrosis? There is a bidirectional relationship here. Can excess calorie diet, regardless of its composition, lead to steatosis? Answer is yes. Can isocaloric, like if you do not eat more than what you need, isocaloric diet, but it's modulated, such as having a high fat and low carbohydrate, or high carbohydrate, low fat, or you have isocaloric balanced diet, but high saturated fat, or isocaloric balanced diet with high glycemic fat diet. Yes, all of this modulation has a significant impact on the energy metabolism in itself, independently. Can insulin resistance and setting over the balanced diet with or without modulation lead to steatosis? Answer is yes. Can normal isolactic balanced diet, isocaloric balanced diet with healthy ingredients composition can lead to insulin resistance and steatosis? Yes, we do have a significant evidence to say that. So what causes non-alcoholic fatty liver disease? There are several factors that causes fatty liver disease that include the unhealthy lifestyle, stress and sleeplessness, alcohol consumption, medication, hepatitis C, thyroid dysfunction, metal storage diseases such as Wilson's disease and hemochromatosis, starvation and parental nutrition, hereditary disorders of lipoprotein, and liver diseases such as alpha-1 antitrypsin deficiency, autoimmune hepatitis. And these diseases, they in itself independently lead to hepatic steatosis independent of other factors. However, there are some other factors that probably may not lead to hepatic steatosis independently, but they may have a synergistic effect on the etiology. And these factors include aging, gender, race and ethnicity, and genetics. Genetics in this, they are different and they are like single nucleotide polymorphism. There are several genes have been identified and that may impact the initiation of hepatic steatosis and subsequent consequences of that. I'm going to discuss the genetics later on. So overall, when you have such a huge diversity of etiologies, and also cofactors that may have additional impact, and that in the practical life, it's become quite heterogeneous population. A person may have, every person, individual may differ. So it will lead to the different disease subtypes, variable natural history, inter-individual variation, and variable response to therapy. So in conclusion, with this kind of a multitude of ecologies, the interaction between the gene and environment is crucial. Genetic factors cooperate with the metabolic and environmental factors to promote the accumulation of fat in hepatocytes. Every individual with steatosis has different combination of environmental, epigenetic, and genetic factors with the unique alterations in nutrition and energy metabolism resulting into one of the three phenotypes. Unique alterations determine the aggressiveness and metabolic consequences, metabolic syndrome features, diabetes, Nash, atherosclerosis, and cancer. Let's refresh the nutrition biology. So when we eat food, we ingest food, and it goes to a series and cascades of biological processes, and that include digestion, and then transport of proteins or transport of ingredients across the intestinal lumen into the epithelial cells, and from epithelial cells to blood and portal venous circulation to the liver, and then to the systemic circulation. So in the liver, there are three different processes happening. One is the recycling, two, deposition and storage, and three is the delivery process and transport to the remaining body. And that leads to the utilization of ingredients by the rest of the body. In order to go through all the biological processes, you need some kind of secretions that have digestion and absorption and reprocessing, storage and delivery, and enzymes. And that enzymes and the secretions are being regulated by the genes and also regulated by the brain and the hormones. So there is a significant high correlation to control the process. These mediators, which are enzymes and secretions, they act as a control, or the gatekeepers. They are the switch to control the biological processes. So if these enzymes, these secretions get modified by the brain, by the hormone, or by the genes, then it alters the whole biologic processes. So that gives you an idea of how the mechanism, how the metabolism works. So when we eat a lot of food, excessive amount of nutrition, and then there is a biological derangement and there's a decreased utility of the ingredients to utilize this energy, then certainly there's an imbalance. We're eating more and spending less, and cumulatively there are more calories in the body to be stored. So just again, that's summarizing etiology, environmental factors, epigenetic factors, and genetic factors. So that lead to the biologic derangements. So now I'm defining the types of biologic derangements. There are four different types of the biologic derangements happen, and that include the insulin resistance, increased de novo lipogenesis, decreased excretion of the bile and the cholesterol in the bile, and wastage of the excess lipids called lipophagy and hypoxia. And so these biochemical key biological derangements lead to steatosis. So just again, so what are the refreshing again? So what are the key players in this whole mechanism of body metabolism? So there are 5 organs are involved: intestine, liver, muscles, adipose tissue, brain, and pancreas. And these tissues are interconnected. They communicate each other by means of hormones and the brain. And the hormones include the major hormone players are incretins, insulin, adipokines, and other hormones such as catecholamines, sex hormones, growth hormone, and glucagon. And the mediators, how these hormones and the brain function come into action is the signaling through the insulin signaling, glucose transport, and the intracellular insulin-mediated transport system. And then there are intracellular transport with the lipases and the nuclear receptors. And then some other kind of mediators are bile acids and microbiota. So here, with all these signaling and concept, the hunger and satiety plays a big role. Before I move on, I want to describe some key facts here regarding this metabolism of the sugar, lipids, and insulin. So the free fatty acids are very toxic. They are always kept at low levels in the cell by the binding to the cytosolic fatty acid binding protein. Apolipoprotein transport lipids in the blood, cerebrospinal fluid, and lymph. They are the central transport system. The fat in the cell accumulate as a lipid droplet. So this is a key phenomena. That's the way the fat is stored inside the cell, whether this is fat in the adipose tissue or fat in the hepatocytes or fat in intestinal cells. And once they are into the cells, then they go through the different processes, such as going through the peroxisome, endoplasmic reticulum, mitochondria, and so on and so forth. And if they're not being used by the mitochondria, that's stored as a droplet. So what is a droplet? Lipid droplet formation may require a family of PFAR. Alpha-induced endoplasmic reticular proteins, termed fat-inducing transcripts 1 and 2, FIT1 and FIT2. The fat droplets are contain a core rich in triglycerides and cholesterol esters, surrounded by the surface layer of phospholipids, cholesterol and proteins. And that includes perlipins and lipases. So the chylomicron remnants, when the fats are absorbed as a chylomicron from the intestine, they go into the lymphatics and then eventually systemic circulation. And then the part of the triglycerides are taken up by the adipose tissue and by the muscles. And then what we are left, but at the end, what we left behind is called chylomicron remnants. And they are degraded in the lysosomes in the liver. Nevertheless, if adipose tissue continues to augment, the compensatory mechanism fails with the sustained rise in insulin resistance and hepatic steatosis. Now talking about the glucose and the galactose is transported in intestinal epithelial cells as the sodium glucose transport. Galactose and the glucose are transported by the similar mechanism. However, the fructose is transported by the different means. Fructose is transported into the intestinal epithelial cells by the sexual facilitative transport system. As much as 20% of the carbohydrate may escape into the colon, and it's metabolized by the microbiota into the short chain fatty acids, and thus derived or readily absorbed. These short chain fatty acids are readily absorbed and go through the portal circulation into the liver to be stored. The glucose is transported into the cell by the GLUT, the glucose transporter, which is a membrane proteins that facilitate the transport of glucose across the plasma membrane. The 14 members of the GLUT have been identified. The monosaccharides are transported out of the intestinal epithelial cells by the GLUT2, just the glucose and the galactose, and the GLUT5 of the glucose, fructose, and the galactose. Insulin only controls the GLUT4, so it only controls the mediation and transport of the GLUT4, and rest of them, they are independent of insulin sensitivity. Insulin hormone function through the insulin receptor. There are two different kind of receptor, type 1, type 2. The type 1 works when we eat during the feeding, during the meal time, and type 2 receptors, they work when in the fasting state. In the liver, and more so that say the insulin hormone signal is tissue specific. So it plays a key role in the regulation of metabolism and aging. In the liver, insulin functioning through the liver-specific insulin receptors. They act on the liver to cause steatosis, to all the excess fat, the storage in the liver, it depends upon the adiponectin. So once the fat gets stored in the liver, then is also further controlled by the excretion, how the liver can promote the excretion of excess fat, which happens through the bile salt and through the bile. So that is controlled by the nuclear receptors FXR. So here the role of FXR comes. The FXR control the excretion and wastage of extra fat and the cholesterol. So what does it do? There are the FXR, the nuclear receptor happens to happen in the hepatocytes and also into the intestinal ileal cells. So their activation by the bile acids lead to decreased bile acid synthesis, increased lipogenesis, decreased gluconeogenesis, and increased insulin sensitivity. So once there is augmented FXR stimulation, it will lead to the decreased bile acid synthesis and decreased lipogenesis, decreased gluconeogenesis, and increased sensitivity. So this is all the effect, desired effect, what we need to treat NAFLD. And when the ileal FXR activation happens, then it reduces the bile acid synthesis, increases the hepatic glycogen storage, increased fatty acid oxidation, and increased FGF19 oxidation. So basically, it burns more fat and get rid of the excess fat by the FXR stimulation. So how the different system talks. So FXR, and then there are also PPAR, peroxisome proliferative activated receptors communicate between the muscle, fat, and the liver. And these fat, again, this PPAR leads to accumulate, disposing, it helps in disposing the excess fat. So there are 4 different kinds of PPAR. So peroxisome proliferative activated receptor, there are 4 different kinds of receptors: alpha, beta, gamma, and delta. So alpha, it helps increases the beta oxidation and decreases steatosis, kind of a more burning of the fat. PPAR gamma, it decreases the steatosis by improving the insulin sensitivity, so it helps to entering the glucose into the adipose tissue and into the muscle cells. And at the same time, it reduces the inflammatory process. As I say that, because the insulin has a role in the intracellular signaling in affecting the inflammatory process. There is the delta, is the increases the beta oxidation, hepatic steatosis, insulin sensitivity, inflammation, fibrosis, and dyslipidemia. So in nutshell, there are 4 things that lead to the excess fat accumulation: influx exceeds the efflux, endogenous fat like a de novo lipogenesis, impaired hepatic beta
At least they have something. Mm. Okay. 5 minutes to your presentation set.
Okay. आवाज नहीं आ रही। इसमें नहीं आ रही।
पहले आ रही थी।
It's नहीं कर दिया। It's like we can't hear. We can't hear the presentation.
छोले भटूरे।
छोले भटूरे लस्सी मैंने पूरी लंबी वाली दिखा दी।
उनको से एक्सेस हुई है, I guess. ये हमारा माइक चल रहा है। No voice from the session और लोगों को भी नहीं जा रही।
टेक्नोलॉजी है अभी इतनी रिफाइन नहीं है।
वहाँ पे
यहाँ पे
प्रॉब्लम
भी
है।
जहाँ पे भी यही प्रॉब्लम होती है। उस दिन मैं लोकल मीटिंग कर रहा था जूम के ऊपर, तो वहाँ पे भी आवाज आ रही है, नहीं आ रही, नहीं आ रही, आ रही, 10 मिनट इसी तरह लग गया।
Okay. Let's see. आवाज नहीं आ रही उनकी। स्लाइडें तो उन्होंने निकाल ली है।
नहीं हो सकता है मुझे स्लाइड चाहिए शेयर करने के लिए।
मैक ने डोंगे लगा दिए
भारतीय नहीं देते भारतीय नहीं देते
ना मेरे पास बगैर डोंगों वाला भी मैक है
ये पुराना
क्या कर रहे हैं कहाँ लिख रहे हैं
pretty simple. Up till recent past, we have been believing that NAFLD is nothing. Every time we do an ultrasound, the ultrasoundologist is going to report on one thing for sure, and that is fatty liver is there. Now, fatty liver, is it something which is benign? Is it something which is just a routine finding, just like a wrinkle after the age of 50 or a gray hair after the age of 45 or 50? Is it just like that, that we are getting this report from endocrinologist or something more than that? And the recent past, and after hearing two elegant talks by Dutta and Shahid, I think we must come to an understanding that this is something which is beginning, and we need to pick up patients right from there and not leave it to a later stage. I don't have any disclosure pertaining to this slide. And straight to my talk, how do we diagnose NAFLD in Pakistan? Obviously, first thing first, we are in a country where we are heavily dependent on our clinical acumen, and obviously the diagnosis has to be based on clinical history, examination, evaluation of body mass index, and certain common laboratories. Now, this is something which is the backbone, this is the starting point. And what do we see in the history? What do we look for in the examination? What are the important things that we are checking in the BMI and lab? There are certain non-invasive markers of steatosis, there are certain non-invasive markers of fibrosis, and then obviously NAFLD always comes in a package. You've heard from Dr. Shahid things about insulin resistance. You've heard Dr. Shahid about increased lipogenesis. So clearly that gives us an idea that NAFLD is always coupled with certain important things like diabetes, heart disease, and central obesity, and so many other things which come in the package, which is called metabolic syndrome. So non-invasive markers of metabolic diseases, they again become an important part in the diagnostic armamentarium. And then we love to send our patients for the test, because unless we send them for the specific test, the patient is not going to feel convinced. And we are not going to be sure whether the person does have a possibility of going on from NAFLD to Nash. And for that, we have certain specific tests. And certain specific tests like ultrasonology, the good ultrasonologist can give us a good idea about the stage of NAFLD. And all those markers and the ultrasonologist criteria that we use in the staging of the liver disease in the DMC, they're applicable in the NAFLD and Nash chapter. But then certain specific like elastography, transient elastography, shear wave elastography, where it gives us an idea about the amount of fat in the liver, at the same time fibrosis in the liver, and the two techniques are comparable, and they're pretty sensitive. And finally, in the advanced imaging modality like CT or MR, where MR spectroscopy or MR elastography are the fine techniques, but how commonly do we really need to go on these? Very, very occasionally, maybe in those patients where those people where we have to have a very fine decision, like in people who are potential donors for liver transplant, we need CT or we need MRE or MRS. Otherwise, in 99.9% of cases, we don't really need the advanced modality imaging like this. So on the clinical side, you have seen this cartoon. We do it almost every day. I'm sure that we're going to have a look at, we're going to have a similar replica of this at the lunchtime, at the dinner time today. And every time we go to a wedding, we can see this kind of great picture. And every time we go out with our kids as well, we see this kind of beautiful, lovely food. But this is something that comes in the clinical history that we need to look at the dietary diary of the person. That how many times we have to go out and see something, eat this kind of food. Are you into a simple, straightforward food, which is free of fats, which is free of rich carbohydrates, or you are more into this kind of food? Those who come from the cities where people love to take big chunk of meat, obviously, this kind of scenario is quite common in the walled city. Again, in the morning, you see the people taking at least 3 to 4 kulchas and all this. And till recent past, every time one starts taking their history on the diet intake, it was more like as if we are giving them body shaming. Similarly, food shaming is something, a concept that the people used to feel offended that, but doctor, why are you asking about my diet in so detail? Allah ka shukr hai, hame sab kuch khane ko milte hai, and we love taking this diet, but not realizing that the problem that they have presented, maybe with the heartburn, maybe with the diabetes mellitus, maybe with the pain in the right upper quadrant, this kind of food in the history becomes very important for us, and we need to look at this. And the type of food is directly correlated with the body mass index of people. Again, one of the important clinical tools. So when we are taking history of these patients, the type of food, amount of food, and their body mass index, we need to match them up with each other. The ones who love to take large amounts of meat, large portions of meat, they always tend to have greater BMI. At the same time, the ones who like taking nihari, paya, biryani, and bakery products, they tend to have more aggressive BMI as compared to the ones who like to take the salads, जैसे ताव साहब खाते हैं, जैसे काश मलिक साहब खाते हैं, कि सब्जियां फल ज्यादा खाएं, रोटी चावल कम खाएं, बिरयानी शरयानी दूसरों को दे दें, सब्जी दाल बगैर तड़के के ले लें. So this is something that we do. And the ones who are more into the resting kind of mode, the desk workers, the executive workers, the ones who tend to rest more, again, this becomes a very important tool in history taking, that how many hours in a day, how many minutes in a day we spend in the gym, we spend in the park to do the exercise. And again, that correlates directly with the BMI, and that correlates directly with the metabolic syndrome parameters, and similarly development of NAFLD and Nash. And these are the important things where we need to remember that the NAFLD comes in a package. NAFLD comes with obesity, NAFLD comes with more weight, NAFLD comes with increased BMI, NAFLD comes with increased eating, NAFLD comes with more rest, and ultimately the impact is that in NAFLD we have abnormal metabolism, we have inflammation, we have development of fibrosis, and that comes in coupling with heart disease and diabetes mellitus. So every patient comes with a possible diagnosis of NAFLD. We have to screen them for diabetes mellitus and heart disease along with. So it's not just the NAFLD that we're dealing with in a patient, because every time in the clinical scenario a patient comes, we are not dealing with a symptom, we are not dealing with a particular disease, we are dealing with a whole patient, and the patient has to be taken in totality and not in the isolation. So what are the key elements of clinical assessment in these patients? Obviously, the key elements in a NASH are two components. One is fibrosis, meaning by the amount of fat in the liver, and the other element is fibrosis in the liver, the degree of stiffness that we have in the liver. And steatosis can be checked through the transit elastography, the commonest tool that's available to us, although it is not available around the country, but in the major centers, yes, it is available. And on transit elastography, on shear wave elastography, it gives us an edge that we can straight away check at the liver fat, and this is called liver cap. And fibrosis, obviously, with the stiffness. And luckily, shear wave elastography machines are available in most of the major cities and not just the major centers. And one can see the reports coming from the smaller cities as well at the moment. So combination of The checking of the fat, steatosis, and fibrosis gives us partly idea. And these are the detailed tools of diagnosis of NAFLD, starting from a simple test like ALT. And remember that in Southeast Asia, the ALT level for females cutoff is 19, although we can still debate on that heavily. What is the normal ALT level for males and females for our people? But there's a rough consensus that for males, any level above 25 is normal, any level above 19 in case of females is normal. So for our population, we need to bring it down to, as in contrast to the stated by European Society of Liver Disease or American Association of Study of Liver Disease, we need to focus more on the guidance coming from the Asia Pacific region or from Southeast Asia region, that we need to bring down our ALT sensitivity level down to 1925 possibly. And once ALT is high, the more the ALT is high, greater the chances that the person is likely to develop complications of NAFLD and Nash in these people. And this ALT is to be supplemented with ultrasonography. And ultrasonography is the next screening tool, followed by confirmatory tools in the form of either the blood test or in the form of specific tests like transient elastography, shear wave elastography, and other tests. The common test that we can do, just like hepatitis B and C, where every Fib4 score and similarly ferritin levels, IgA levels are pretty sensitive in picking the right on people. So not each and every patient we need expensive modality like transient elastography machine, shear wave elastography machine, but we can do it with the simple laboratory tool as well, the lab test as well, which in any case have to be done in these patients, and they are the important monitoring tools as well. Every score is available in almost each and every hepatitis clinic. It is inculcated into the software of that hepatitis clinic, which is now available in 152 centers in Punjab, and similarly in the other provinces as hepatitis clinics are coming up, and the Punjab government is ready to share their software with the other provinces as well. And then expanded lab and SIS, although we're not using it regularly because proprietary tests and their expensive tests like fiber tests and fiber tests. And then obviously direct fibrosis markers, ELF test and PII, NP test, though we're not using it in routine. So to make the thing simple, ALT, ultrasound, transient elastography, shear wave elastography available. Otherwise, EPRI and FIB4 are good enough to give us a baseline and then monitor them further. Unfortunately, if we look at the ALT alone, in as many as 23% of patients, ALT may be normal and still the person may have a significant steatosis, but at some point in time, this ALT is going to go up, and at the same time, if we look at the literature, because there is so much of variability of ALT in the literature as a benchmarker, so it is always difficult to interpret the studies. But in majority of the patients who are suffering from NAFLD or Nash, ALT is definitely above 19 in the case of females, about 25 in case of males. So just to summarize, work of NAFLD, we need to stratify the risk as well. There are certain SIDA patients, straightforward patients, age is young, FIB4 is less than 1.4, and there are no features of metabolic syndrome like obesity. There's no diabetes like this. The chances of ischemic heart disease are minimal. Similarly, family history is not that bad in the younger age. In those cases, just like the station which was made by Dr. Shahid, that we just need to concentrate on the lifestyle intervention, monitor the patient, and repeating the non-invasive markers of fibrosis and disease progression, or maybe the sophisticated like tests like shear wave elastography or transient elastography. And then there are certain group of patients as we age, we all understand the chances of development of diabetes, development of ischemic heart disease get worse. So in the people above the age of 40 who have the features of metabolic syndrome, in these cases maybe liver biopsy, may also need to be done to convince the patient that they need a definite lifestyle modification, weight reduction, and possibly pharmacotherapies which are going to hit the market in the coming days. Although right now, although this is not my topic, Dr. Bala is going to take up on the treatment of NAFLD and Nash. But certain drugs which are very like vitamin E can be given in these patients. But bottom line is that we have to convince these patients for continuous compliance on these medicines, and that can only be done when we have a definite evidence. And finally, the people who have progressed to the cirrhotic stage, just like hepatitis B and C, in these patients, we have to follow the patients just like any other cirrhotic, meaning by that the surveillance for hepatocellular carcinoma and complications of liver disease and complications of cirrhosis of liver need to be monitored in these patients. This pathophysiology has been done in detail by Dr. Shadri, so I'm not going to take much of your time, but just to emphasize once again that this is the cascade that we need to follow in the follow-up of these patients who are suffering from NAFLD Nash. It is not a simple, straightforward NAFLD Nash. It is a combination of so many things, which includes the lipid matrix abnormality, which includes carbohydrate matrix abnormality, the cell death, and then diabetes, mellitus, ischemic heart disease. All these things become in package, and this package has to be dealt in these patients when we are following these patients, not just the liver alone. And in following that, again, these are two things that we have to follow. One, steatosis, the other one is fibrosis. In the steatosis, obviously, the resolution of accumulation of fat, and that is done again either with the non-invasive markers or maybe with the at times invasive markers, depending on the type of patient that we're dealing with, and fibrosis with the transient elastography, shear wave elastography, or fibro test. This is something that we need to do. When we are monitoring these patients, every time a patient comes, weight management, weight monitoring, and emphasis on weight becomes the most important thing. And unless we are monitoring the weight, we cannot convince the patient that with this weight reduction, this is what we are going to achieve. More the weight is reduced, greater the chances that we're going to we're going to reverse the steatosis, we're going to reduce the fibrosis in a given patient who's suffering from NAFLD or Nash. And how can we do this? Again, since Dr. Balapias is going to take up the management in detail, but just a quick slide that these are the important steps based on which we need to monitor the weight on these patients and follow target for NAFLD. You have seen this picture, a girl which was seen in dramas. It used to be quite big, and then this is recent. The message again with the advocacy groups: weight reduction, weight reduction, weight reduction, and we need to monitor as hepatologists, as gastroenterologists in these patients, so that we may be able to help our patients in improving their NAFLD and Nash. Thank you for your patient listening.
Thank you, Professor Reyes. Our next speaker for today's session is Dr. Badr Fayaz Zuberi. He is working as a professor, dean and chairman, medicine and allied sciences at Dow Medical College, Dow University of Health Sciences, Karachi, and consultant physician and gastroenterologist at Medical Unit 1, Dr. Ruth Kempau Civil Hospital, Karachi. He has thrice received Young Investigator Award on his research papers and has more than 80 publications in local and international journals to his credit. Professor Badr Fayaz Zuberi will talk on tackling NAFLD, what treatment options are available in 2021.
Assalamu alaikum. I thank the organizer for giving me the opportunity to speak on this August forum. Can I have like well, there has been a very good prelude to my session by Dubna Kamani Shahid and Professor GNT Yasin Ali Tayyab. And the task and the case has been built up very good and nicely. And I have to follow up on the treatment what we are going to offer and what is available now in 2021.
अस्सलाम वालेकुम। एक कार है LED 7292 here right in front of gate है and it's posing security issues. LED 7292 तो प्लीज अगर किसी की है तो फौरन जाकर उसको रिमूव करें।
So let's begin what we already know and what is the current status of guidelines regarding the treatment of NASH. Something that has been updated now with the status of metformin, that it is currently no more recommended in treating of NASH in adults. It improves the liver enzymes and insulin resistance, no doubt about that. But it does not significantly improve the histology of the pathology of NASH. Regarding GLP-1 receptor antagonist, it is a premature to consider at this level to treat liver disease, as we do not have much of the evidence present in this area. Some other drugs that have been shown to have some activity against NASH and NAFLD, like pioglitazone, anti-diabetic drug. It has shown that in the biopsy-proven NASH, it improves liver histology in both the groups of diabetic and non-diabetic patients. For vitamin E, it can be used only in non-diabetic patients. In fact, in diabetic patients has not been used. Now, these two drugs, pioglitazone and vitamin E, have some serious side effects for which the risk-benefit ratio has to be discussed and individualized for all patients. But whenever we are trying to prescribe these drugs, that will deal in detail next time. Now, what's the evidence? If you look at the evidence here, so histological features, ketosis, fibrosis, and all these markers and which we assess the liver, fatty liver and NASH. And you see that both these drugs, in which this blue one is vitamin E and green one is pioglitazone, they show a good effect with significant p-values on histological improvement in ketosis. But in fibrosis, not so much of significant value, although there is some improvement, but not reaching to practical level. Globular inflammation is also one of our markers of ketosis, and we see there is a significant effect in which in here it is the pioglitazone having better effect. And then in hepatocellular ballooning, we have a better effect with vitamin E, and then a resolution of NASH. So only in fibrosis, there is a limited effect of these two drugs. Rest of the effects, they are having a good effect. And what about in diabetics? So in diabetics, vitamin E cannot be given, so only the results of NASH. And in a randomized controlled trial in a phase 4, it showed there is a more than 2-point reduction, equal to a more than 2-point reduction in NASH activity scores, and it shows that a significant effect has been achieved. In resolution of Nash, again, a very good effect, but in fibrosis, again, pioglitazone failed to have a significant improvement over the period of time. What about vitamin E? Vitamin E has shown a transplant-free survival improvement and improvement in the risk of hepatic decompensation. So these two effects have been shown in this study, which was conducted over a period of more than 5 years, and shown that a better response of vitamin E has been documented in transplant-free survival and hepatic decompensation, as shown by these two graphs. Now we come towards the safety and tolerability and recommendation therapies of these, and they are still off-label. Vitamin E given in 800 units per day in 2 divided doses. It has a possible all-cause reduction in mortality. It has a significant increased risk of hemorrhagic stroke. Now, this is the problem with vitamin E. But it does show a small reduction in ischemic stroke presentation. It does have an increased risk of prostate carcinoma in these. So these two red flags with vitamin E are the deterrent for taking a decision while you want to treat them with non-diabetic patient of NASH with the vitamin E. Regarding pioglitazone, there is a risk of weight gain of 2 to 3 kgs over 2 to 4 years. This again nullifies all the benefit that we want to achieve by reduction of weight and by the prolongity and other cardiovascular risk factors reduction. These are hampered by giving pioglitazone in long-term basis. There is a risk of osteoporosis, more in females, and definitely controversial risk, increased risk. Some studies say, some studies don't, a risk of bladder cancer in the future. So why we take a decision of taking these two drugs into our armamentarium and using them around patients, we have to individualize and see the risk-benefit ratio of these two drugs in management of NASH. So what would be the current available treatment options and the targets? Number one will be the control of obesity to reduce cardiovascular risk factors and target specific NASH therapy has to be. Now, control obesity with lifestyle modifications, diet, exercise, which we tend to have very beautifully described by Vyas that we like to eat, everybody likes to eat. And with the change in the pattern of our dietary habits of our children, seeing more and more of obesity in childhood obesity, coming on, lead on to the adult obesity also. Some weight loss medication, bariatric surgery. Now, this is a very thing that has come on and has shown some promising results, which I'll be discussing later. Reduce cardiovascular risk by treating better managing type 2 diabetes with and their hyperglycemia, their hypertension, and their dyslipidemia. And with liver-directed treatment, and two of them we have discussed, rest I'll discuss now. Next slide. Now, what are the emerging new treatments? And these, when we see, this is how does the liver behave? Everybody knows that there is a fat infiltration of more than equal to 5% without ballooning or inflammation is non-alcoholic fatty liver. And when there is a ballooning or inflammation or Mallory-Weiss or megametastase, it becomes NASH. And then in the end, it becomes cirrhosis. And any cirrhosis can lead to, regardless of its cause of emission, into hepatocellular carcinoma. So I'm repeating the slide used by Professor Riaz that what are the targets for our management for NASH? The NASH, there should be resolution of steatohepatitis overall, but there should be no worsening of fibrosis. So it should not be any drug that can improve one parameter and worsen another parameter. So we need an improvement in steatohepatitis without worsening of liver fibrosis, and on the other hand, improvement in fibrosis without worsening the steatohepatitis. So these two parameters should be fulfilled for any drug to be used for our NASH or NAFLD patients. So some experimental drugs which are still on, these are the drugs. This is cimitrivoroc, and it is showing a primary, and study is showing a primary endpoint of more than or equal to more one-stage fibrosis improvement with no NASH worsening. Elafibranor, obeticholic acid, remistron, and amacor. So let's talk one by one. This drug, which is a CCR2 and CCR5 inhibitor, as described in detail by Professor Shahid in his talk, that this drug blocks the combination of inflammatory markers, macrophage, with stellate cell. Now, stellate cell, as you all know, is the hallmark of inflammation and degeneration of fibrosis in liver. So its activation leads to fibrosis and inflammation and leads to cirrhosis. So this drug blocks at this point. So it probably, theoretically, limits its progression into the dangerous sites of the liver. And what are the results of its trial up to now? It has shown small improvements in the 2-point NASH activity score improvement and no fibrosis worsening, and it has shown some better effect, but still it has not reached to the statistically significant mark. And we look at the subsets of these patients in which we see that it is a maintained more than one stage fibrosis improvement from 1 year. So some effect has been documented by this drug, but has up till now, as the trial is in the phase 3, it will come into phase 4, we still have small improvements, not a major improvement in this trial. So it did have adverse effects not to migrate in this patient. Now, this elafibranor is a PPAR alpha and PPAR gamma inhibitor, and it reduces the fatty acid oxidation, triglyceride lowering, HDL rising, and inflammation. And while the gamma one leads to lipoprotein metabolism, glucose hemostasis, and energy metabolism and inflammation. And the results of this drug of over a year trial with placebo control does show that in some of the that disappearance of ballooning, disappearance of mild resistance and lobular inflammation with the dose of 120 milligrams per day has shown a significant improvement in these drugs, while a lower dose of 80 milligrams did show some improvement, but not to a significant balance. A new fad has come up with obeticholic acid. People are very interested and has created a hype about this. This results in FXR debilitating inflammation and again preventing stellate cell activation. And this agonist, FXR agonist, acts as, and we see that in a randomized controlled, placebo-controlled trial, again, we see a very good improvement between a placebo and a 25 milligram dose of p-values of highly significant. And again, a 10 milligram dose also had a very significant improvement in the primary endpoint of fibrosis improvement by more than one stage, which was one of the criteria we discussed by the earlier by by ASLD. Now, Nash resolution, again, it didn't have much of the benefit in this study. Now, thyroid receptor beta agonist drug, Reniston, is having a lot of action which are described by Dr. Shahid. I will not go into details, but I'll talk about its efficacy of 12 weeks treatment, and that shows that in Reniston, there is a significant reduction and relative change from baseline from relative fat fraction assessed by MRI PDFF. So fat reduction, this has decreased in this chart. So now the link between non-invasive measures and liver histology, and we have to see that a 10-unit reduction of ALT is associated with histological improvement or resolution of Nash, and equal to a more than 17 units of ALT reduction predicts histological response. Now, this is very good, a marker, a non-invasive marker which we can set targets now, that how the Nash and NAFLD is going to behave and what should we be aiming at in our treatment of these patients. And this investigation of MRI PDF is on that form. It's very expensive and not readily available even in Pakistan. So more than 5 or equal to 5% absolute reduction is associated with the improvement of ketosis, and equal to a more than 30% relative reduction is associated with improvement of NAFLD and activity score without fibrosis worsening. So now we have non-invasive markers on which to predict how our patient will be behaving and what we should be asking the patient to do. Now, from where we started with fibrosis improvement and Nash resolution. And as Nash progression to clinical outcome takes years and years, so trials of Nash treatment to examine surrogate markers have become important. So you cannot do these markers in our lifetime. So they need more than 3-4 lifetimes before we can become wise to how they have behaved. So 2 or 3 generations are required for this treatment, but there are surrogate markers on which we'll be focusing now, as I told you one of them earlier also. And the evidence lies that the NAFLD and liver fibrosis is a risk factor for adverse death. As you see, there is a severe liver disease. You see more problems in F3 and F4, and liver disease mortality you see more in F3 and 4. And so the NAFLD is a reverse outcome of have a poor outcome as the disease progresses. So one evidence is there. And another evidence that regression of Nash cirrhosis is associated with improved clinical outcome, and this has been shown that improvement in Nash fibrosis was associated with lower risk for liver-related events. And there is, you see, there's this study had by Sanyal, presented in ASLD 2020, showed irrevocable evidence that if we do these, achieve these targets, there is a better outcome of the patient. Now, is Nash reversible? Again, the evidence comes from a single center study from bariatric surgery in severely obese patients with biopsy proven Nash, and it shows that a BMI loss of 5 lead to a resolution improvement of 5 to 10 points of BMI loss lead to 80%, and more than 10 BMI points loss lead to such a resolution. And after you see on the same time of evolution of fibrosis after bariatric surgery at 5 years, you see a much of the improvement have come from this F0 has become this level of F0. So what we have evidence that Nash is reversible, and how it was done by a bariatric surgery at that time. So importance is that if you reduce weight, no matter how you reduce it, will have a beneficial effect on Nash. Does the reversal of Nash improve fibrosis score? And the evidence has come up from a study presented in JAMA, and the fibrosis state change with Nash activity scores has shown that as the stages were reached in the first and the last biopsy, and the two biopsies sequential on the same patient. So as the improvement of Nash has occurred, there has been improved in fibrosis score. So two major points have shown that there is an improvement on these parameters if we acquire these. Or where we are heading now. Now, after reducing heading, we need to have a weight loss, estrogenic lipid profile improvement, and glycemic control on these patients before we have a very good outcome on these patients. So let's see a patient, a hypothetical patient of Danish who had an F3 hepatic fibrosis, biopsy confirmed Nash, type 2 diabetic, obesity, and dyslipidemia. Now, what is current situation is? There is no approved treatment for him for Nash. He has hyperlipidemia, obesity, and his trend is going downhill. How we can treat will be based on data generated today and the agents currently being studied, which I discussed earlier. So, Mr. Danish is at a high risk for liver outcome because of his F3 stage and liver disease mortality of 16.9% because of his fibrosis state. Now, what we can do is to reduce the prevent from fibrosis, reverse the Nash, and we can have a better metabolic profile if we go towards his obesity, type 2 diabetes, and dyslipidemia. Now, multiple agents are in development, and there are some oral and injectable, and these will affect on his control or better of dyslipidemias, diabetes, and will have a favorable outcome on his Nash. So, among them, we have FXR agonist, obsicolic acid, PPAR, in which pioglitazone we have discussed. We have Venestron, metabolic enzyme inhibitors, and on the other hand, injectables, we have GLP-1 receptors, and among them, semaglutide has shown a better response than on competitors in her class. Now, what are the advantages and disadvantages using an injectable or oral therapies? We discuss now that in injectable potentially very potent on histopathology, unknown effect on GLP-1A receptor, and potential effect on metabolic profile. So practically, they have a faster action and a rapid action, but definitely cannot be continued on a very long time. They have a short-term induction therapy can be used as in F3 and F4, and used in F4 with rapid fibrosis progression or risk factors with significant metabolic comorbidities can be advocated. When we have oral approaches, they have a variable effect on histopathology as compared to the injectable ones, and variable effect on metabolic profile, but they have a favorable route of administration, may be well tolerated by the patient, then acceptability will be higher. Possible uses of long-term treatment and maintenance, that is starting with the injectable and maintaining them on oral therapy, and on some multiple drug combinations can be given in this patient. So it's a busy slide which shows injectable therapies which are available with the GLP-1. You see there's a better response with semaglutide as compared to the others. We also have shown in fact of the Nash resolution with no fibrosis. Again, you have a semaglutide having better response, and there is no such difference. So different bars have shown, and we have a Nash resolution with no fibrosis worsening with semaglutide. The secondary endpoints, again, you see the different doses of semaglutide have shown that 0.4 milligram dose has shown a better response of improvement in Nash as compared to the lower dosage. Now, talking about hepatic outcomes of oral agents associated with various rates of patients with Nash resolution and associated with various rates of patients with fibrosis improvement. And these drugs, when compared with extra hepatic manifestation, we have to be very cautious because the patient is having other cardiovascular morbidities and problems that need to be addressed. So his obesity needs to improve, his type 2 diabetes and glycemic control has to improve, his dyslipidemia has to address all these factors for a better outcome on these patients. The extrahepatic outcomes of oral agents associated with various reduction in triglycerides and associated with various reduction in LDL as raised to aldosterone and amistron. But one of the side effects of the ketogenic acid was that it, in some patients had shown that it increases the LDL value. Some also associated with reduction in HbA1c or body weight, and by contrast, the lenifibranor is associated with increased weight. So this group with pioglitazone have an increased weight, while the others may have a better response on this. Weight loss analysis has shown that weight loss has shown, as I talked earlier also, a better resolution of in Nash and fibrosis. Both of these graphs shows a very good improvement if these two targets are met in our patients. So in short, we can start with injectable and then come on towards oral therapy, which may be the future in our patients, and having targeted fibrosis improvement, Nash resolution, reduction in lipotoxic fat, weight loss, and this is the pyramid we are talking about in our patient in future. So summarizing my talk today, that the histological liver endpoints are currently accepted endpoints for Nash treatment. They're reversible on Nash or fibrosis without worsening of the other. Very important. And the extrahepatic endpoints may have a role, which is the better glycemic control, and the atherogenic risk has to be addressed because these two may have a cardiovascular mortality may be very higher, even if we are trying to treat the NAFLD. So I thank you for your patient listening. Thank you.
Thank you, Professor Badr Fayaz-Zubairi, for a nice and elaborate talk. Now we have a question answer session. We have one question for Dr. Shahid Habib from the audience.
Yeah.
What is the relationship of genetic factor in development of HCC in non-cirrhotic, non-alcoholic fatty liver disease? Question from Dr. Shahid Habib.
Hey, do you hear me? Do you hear me? Audio. Do you, Mike? Do you hear me? Phone call.
Phone call. Yeah. Three, 5, 8, 7, 6, 2.
Closing this session, and welcome Professor Anwar Khan in 21st Annual Congress of Pakistan Society of Hepatology, and request him to come on stage and present the certificates to our worthy speakers and chairperson, Professor Anwar Khan.
Number 7952.
6186.
Our first speaker is Professor Fayaz Nabi. Professor Anwar will present certificate of participation in the first annual Congress of Pakistan Society of Hepatology.
Hello. Do you hear me? This is Dr. Shahid.
Hello.
I welcome our next speaker, Professor Badr Fayaz Zubairi, to receive the certificate of participation.
Hello.
Professor Mozamuddin to receive his certificate of participation from Professor Anwar Khan. Professor Khalid Shah to receive his certificate of participation. Dr. Muiz Atar
Hello. Yes, sir.
and myself, Dr. Dawood Gulzai.
I can answer the question if you want me.
Professor Shahid Habib is online and he will answer the question.
Can you just repeat the question for me?
Yeah, I will repeat the question. What is the relationship of genetic factor in development of HCC in non-cirrhotic NAFLD?
Well, there is no clear-cut pathogenetic mechanism have been identified, but there is some evidence that the patients with NAFLD or steatosis have higher level of microRNA. And the microRNA is a reflective of intracellular activity of both inflammation and the fibrosis, and they correlate with the chances and probability of developing cancer. And this microRNA analysis is actually becoming the tool to assess the aggressiveness and the behavior of the study. We just finished the participation into a clinical study where we did the narrow gauge needle biopsy to take the very minute sample of the liver to assess the microRNA in the liver. But yes, as of today, clinically, yes, we see a higher probability of developing HCC both in cirrhotic and non-cirrhotic liver. But the clear linkage between the NAFLD and HCC is still yet to be determined, but certainly there is a link of microRNA.
Thank you, sir. Now we have a tea break, and along with it, we have our inauguration of exhibition area by Professor Anwar Khan. Thank you. Our next session will start with 5-minute delay on 11 a.m. Thank you.
Thank you.
Enter the session.